So I'll be speaking on medical management of GCT. So the mainstay of treatment is surgery. So I don't want any bad ideas to be taken that denosumab can compensate for a bad surgery. After a very extensive talk by Dr. Raj Segar and Dr. Devendra on beautiful surgeries, I'll be enumerating exactly where denosumab plays a role in these patients. So indication for drug therapy is unresectable disease if a patient is supposedly unfit for surgery, and in overall GCT, only 15 to 20% of these patients will need a neoadjuvant denosumab. That too to facilitate curettage or convert a resection into a curatable lesion or to facilitate a resection. I'll give you examples for each of these, and the role of denosumab as adjuvant after resection or after complete curettage is not known. So, what is converting a resectable lesion to a curettage is when you see such a lesion, which the almost all three walls of the distal tibia is gone, and in such a case, we might need to use something as a neoadjuvant setting, either to do a good resection or to convert a resectable lesion into a curettage. So, what is facilitating a resection? And when you think of such a lesion, when the lesion in the proximal tibia involving both the anterior and the posterior compartment, encasing all the neurovascular bundles and causing encasement of the fibula, we can be using denosumab in such a patient to facilitate resection and to assess response later. So, what are the options of treatment? Initially, when before denosumab came into play, that is a targeted therapy came into play, the what was being tried were radiotherapy, which had converted what is called a so-called a benign lesion, and there had been a lot of malignant transformation of a benign GCT. So the radiotherapy has fallen out of flavor. Next comes cisplatin-based chemotherapy. Again, in a benign lesion, the response rates are extremely low. Chemoembolization has also been used extensively before surgery, and the response duration has always been transient. Bone modifying agents have been tried, like zoledronic acid, before the advent of denosumab. So, as we all know, denosumab acts is a targeted therapy, specifically targets the rank ligand. The mechanism of action, which I will come into later, it is FDA approved in 2013. Initially started for treatment of osteoporosis. Now it has been extensively used in osteoporosis, GCT, metastatic bone tumors like breast, prostate cancer, and many others, and multiple myeloma. So you can see this one, the pink one is the tumor. So it stimulates the stromal cells on the osteoblast to produce the rank ligand, which in turn stimulates the osteoclast to produce the giant cells. So what happens to what the denosumab does is inhibits these rank ligand and prevents proliferation of both stromal cells and osteoclast. So in turn, reducing so when you take a resected specimen of a GCT and analyze in the pathology lab after treatment of denosumab, it shows that it can eliminate up to 80 to 90% of giant cells and reduction in stromal cell density. And there is increased new bone formation in places where stromal cells were positive for rank ligand. But you should note that there are three components of a giant cell tumor. One is the giant cells and the stromal cells, and third one is the tumor. That there is no tumoricidal effect by denosumab. So, if when we look at a lesion like this, how do we decide on giving a denosumab? So, what do we do before starting denosumab for a patient? So mandatory things that has to be done are looking at the serum calcium value, because there can be hypo or hypercalcemia in these patients, which has to be corrected. Second is a phosphate value, because denosumab can cause hypophosphatemia and anemia. So the second most important thing is doing a dental evaluation for all these patients. Because if the patient has infected tooth or dental caries or recently undergone any dental treatment, the denosumab has to be delayed or started late because it can cause osteoradionecrosis of jaw. Suppose if the patient has undergone a recent dental procedure, then denosumab should be delayed up at least 8 weeks, and it is safer between 8 to 12 weeks to prevent late complications like that or osteonecrosis of jaw. So, what is the dose that the denosumab should be started? The denosumab should be started at a dose of 120 milligrams subcutaneously on day 1, day 8, and day 15. That is weekly doses. The first 3 doses will be weekly, then it will be every month. And calcium and vitamin D supplements also are started along with denosumab. Neoadjuvant treatment. So, how long should this treatment should go on? If you are thinking in terms of neoadjuvant treatment, you should assess the patient periodically, and the treatment terminates once the necessary response is achieved. That is, you think if you are giving it for converting an unresectable lesion to a resectable lesion, then once you think you have achieved your goal, the neoadjuvant treatment should stop, which is usually between 3 to 6 months of treatment. In metastatic setting, we usually treat until progression, or patient can be off treatment once the patient has become asymptomatic, or and it can be restarted once there is progression of symptoms. There is no phase 3 evidence for doing either of this, but this is what is done in real time. So, based on various studies, the usual treatment of denosumab has been varied between somewhere between 16 to 15 months, 6 to 15 months. How do we assess response? Once we have started denosumab, we know how long to give. How do we assess response? It can be either clinical or radiographic response. Clinical response in terms of pain. If the patient pain score has come down, whether the swelling size has come down, if it is around the wrist joint, whether the wrist movements are, or if it is around the knee joint, whether the knee joint movement is better, or if it is in the ankle joint, whether the movement is better. So ability to bear weight bear is also another example that patient has responded well. If the patient has any skin changes because of stretching skin or discharging sinuses, and we can assess the response by assessing whether it has healed better or not. So, how do we radiologically assess response? It's usually done between 6 to 8 weeks. That is usually after 2 doses. So, after every 2 doses, we need to assess a response. What do we find in them? There is an ossified rim, and there is a reduction in soft tissue component, improvement in the subchondral bone thickness, and there is increased ossification in the lesion. So, once this response assessment is done, we know in a neoadjuvant setting, if we have achieved our goal, we should stop treatment. Why do we stop treatment? Because of the we don't know the long-term effects. And what are the adverse effects of denosumab? The hypophosphatemia can happen. There can be back pain or generalized body pain, anemia, hypo or hypercalcemia. Either of this can happen. Osteonecrosis of jaw. This usually happens when the patient has dental caries or some form of dental infection, and usually at approximately at 1 year of treatment. This is why we need to reduce the treatment duration. What is the dreaded side effect, or probably a missed biopsy? Because as we know, giant cells can be seen in a lot of other lesions. This can be either a dreaded complication or a missed biopsy. Long-term treatment of denosumab can cause a high-grade sarcoma, can even cause sometimes a high-grade osteosarcoma. This has been reported in literature, and have been 11 cases across various studies. So, what is the recurrence rate? Is there any reduction in recurrence rate when you pre-treat with denosumab, or it's just only the conversion? There has been a systematic review and a meta-analysis looked at this, and they have very clearly said that there is no difference in recurrence rate whether you have treated with denosumab or gone with upfront resection. It's just the conversion rate of a resection to a curate or unresectable lesion to a resectable lesion that has changed. So denosumab per se has not reduced much of a recurrence rate. What can be the cause of these recurrence rate to be same even after there is a clinical or a radiological response? As we know, denosumab acts only on osteoclastic giant cells and the stromal cells, this is not a tumoricidal. There can be tumor cells that get embedded in the new bone, and the fibrous ossification that happens with the treatment of denosumab can result in a difficult delineation of the extent of tumor. So suppose if we started denosumab and the lesion is not responding, the first differential diagnosis should be a giant cell rich non-GCT tumor like a osteosarcoma, STS, or a malignant fibrous histiocytoma. So a repeat biopsy has to be done, which has to be definitely guided. So what is the evidence? We have spoken so much about the duration of treatment. What evidence are we speaking on? So it is all phase 1 bar phase 2 trials, but the response rates have been excellent. Do you have any Indian evidence? Yes, there had been a paper from Tata Memorial Hospital, which is a prospective data, which is not which is of a 44 patients, where they have had good response. What is ongoing is the Japanese study JCOG 1610, which is a phase 3 study which has started in October, which results are expected in 2021. And this they have trying to evaluate the superiority of denosumab. The prime endpoint is being the relapse-free survival. As we have spoken, the radiotherapy in a benign lesion, which can chance of benign tumor into a high-grade malignant tumor, it has fallen out of favor. But what's new in radiotherapy? As we all know, the denosumab acts only on giant cells and stromal cells. It leaves behind residual tumor cells. They have been evaluating, is there a role for radiotherapy in post-treatment after denosumab to irradiate those tumor cells? The results, the studies, this concept is new and they are evaluating this. So phase of denosumab where bisphosphonates were used, but these trials have come to early closure. These were all phase 2 trials which came to early closure because denosumab showed a very good response. So this are all retrospective and phase 2 trials, and the only role for bisphosphonate in Indian setting would be a non-affordable patient. And but the problems of IV nature of these drugs and the oral bisphosphonates have not been evaluated in this setting at all. So coming to metastatic GCT, the treatment is still surgery. In a resectable stage, we would like to go ahead with surgery because surgery gives a complete cure. In some metastatic lesions, even we can observe those lesions for 2 to 3 months and see if there is rapid progression. And only surgery is indicated on all resectable cases. VATS has revolutionized this treatment of lung metastasis, not only in GCT and across wide ranges of other bone and sarcomatous tumors. Denosumab is only used in unresectable metastatic disease, and duration of treatment is still not known. Chemotherapy response rates are around 2%. So I would like to not confuse you. I would like to answer some straightforward questions. Treatment of using of this targeted agent. The indication for denosumab remains only in metastatic, neoadjuvant, unresectable, or unfit patients. All others, surgery becomes the mainstay of treatment. The dose is 120 milligrams subcutaneous 3 weekly, then monthly. In case of neoadjuvant setting, until your target is achieved, you can treat, and in metastatic setting until progression or patient is symptomatically better. So usually this preoperative denosumab, the conversion happens within 3 to 6 months, but there are no phase 3 studies. Continuation of denosumab postoperatively should be continued postoperatively. That is, don't defer it role, but people have used across various studies up to 6 doses, either monthly or 3 monthly interval. Any role for adjuvant denosumab after resection? There is no role. Recurrence rate after denosumab, same as in primary setting, if not continued postoperatively. So long-term effects of denosumab are unknown. There are reports of high-grade sarcomas, so it has to be used judiciously. So what is awaited is the the phase 3 trial, which will bring us a lot of light. Thank you.